All right. Well, good morning, everyone. Welcome to Cardiology Grand Rounds. Before we get started, I'd just like to bring a public service announcement. And this is one of our featured studies. It was just approved, called the EXACT trial, sponsored by AskBio, or also called the Nanocore trial. And this is a gene therapy study using an adeno-associated virus that's for patients with non-ischemic cardiomyopathy with usually class 3 or class 4 symptoms of heart failure. And it targets the SERCA2A pathway, which is involved in calcium handling in the heart, which we know is kind of deranged in the failing heart. So this gene is delivered by an intracoronary infusion down the coronary artery. So, not like some of our other gene therapies where we actually have to do intramyocardial injections, which are a lot more invasive. So Jane and Jacob Jensen are working with me and the heart failure team on this. And so we'll certainly be looking for patients. We know they're out there. They finished the first cohort. There's 4 doses, and now they're starting the second cohort. So we'd like to obviously get involved in this important study. And here's my disclosures. I have nothing, unfortunately, financially to disclose. I will discuss some stem cells, and then just to clarify, I'm not an MRI expert by any means, but what I'm going to talk about is very MRI based, and that's what's called microvascular obstruction, which we see in the setting of ST elevation myocardial infarction. And just over the years, this sort of kind of evolved of an interest of mine because of how it impacted the results of many of the clinical trials that we've been involved in. And it's never, when you look back at like a lot of the STEMI literature, these patients with MVO are totally different beasts than the other patients that don't. And it really should be accounted for when you're analyzing your data because its effects are so powerful. So it's seen in about 40 to 70% of our STEMI patients, and you can see it on an EKG as manifested as persistent ST elevation, or when you're doing an angioplasty and a stent, when you frequently will get no reflow. That's all due to microvascular obstruction. The etiologies of it are many and diverse. They include, which we most commonly believe is the distal atheroembolic debris and platelet and white blood cell clumping inside the vessel. There's the development of microvascular dysfunction following the ischemia reperfusion injury, which contributes to it. But there's also an outside-in effect of microvascular obstruction where there's extrinsic compression of the microvessels. You know, those capillaries are very thin and fragile, and with increasing edema and extravascular compressive forces that we'll talk about, that they basically can shut down those vessels. So you can get occlusion either inside the vessel or from outside the vessel. And then there's also the loss of the vascular integrity due to intramyocardial hemorrhage, which associated with MVO. It's also a very powerful finding and associated with adverse remodeling and poor outcomes. So this is just an example of an EKG of someone who actually underwent LAD angioplasty and stenting, but you can see the persistent ST elevation in those anterior leads, and this is sort of pathognomonic for ongoing microvascular obstruction. And this patient is going to not do well over time because they'll probably have adverse LV remodeling, so their heart will enlarge and probably end up develop heart failure, will have increased risk of death, increased needs for defibrillators, etc. This is an MRI representation of MVO, which is represented by this hypo-enhanced region inside the hyper-enhanced infarct region. So you always usually see MVO inside the infarct region. We know that MVO is associated with larger infarcts and more prolonged ischemic time. But we also know it's interesting doing a lot of these procedures is that the first patient I may do, very similar, has a lot of MVO, and then the next patient we do has same amount of ischemic time, the same LAD artery, and yet has no MVO. And it's always been a wonder to me. It's like, why? Why do some people get MVO and others don't? And we know some reasons for it, but it's also, to me, it's still sort of an enigma that really needs to be determined. So you can measure MVO either what's called early MVO or late MVO. The early MVO is immediately after you give a contrast agent such as gadolinium within 2 minutes, and that's basically a lack of the contrast agent getting into the myocardium. And then there's late MVO, which is when you take your imaging pictures 15 minutes after. So early MVO is much more sensitive, but late MVO is much more specific because, you know, there are other things that can contribute, such as edema and so forth, to make the early MVO more positive. So late MVO is more specific for true microvascular obstruction and is probably more associated with worse outcomes. So here's just when I talked about, here's a couple of different patients that we'll look at. So here's an 89-year-old female who had 20 hours of shortness of breath and chest pain, and you see she still has some slight ST elevation in those inferior leads in 2, 3, and AVF. And here's her, I don't know if it'll play. Well, I guess I'm not sure why it won't. Do I have to? Okay, there you go. So you can see here, so she presented on the left with an occluded right coronary artery, proximal occlusion that we opened up and stented. But you can see how slow the flow is going through that artery, and there's just persistent staining in the microvascular. So this is pathognomonic for her having microvascular obstruction. So she's going to likely have a very dense infarct in that region. So here's then another older gentleman who has diabetes, who had ongoing chest pain for several days, and you can see in his anterior leads still has persistent ST segment elevation. So he's brought to the cath lab, and he then undergoes angioplasty and stenting. You can see his LAD was occluded, but now we open up his LAD and put a stent in there, and you can see that that there's really brisk flow down the vessel here. So I don't know, it's not showing, but I think you saw the flow through his LAD artery was actually very brisk. And so he had little MVO. Now it's possible he's several days out that actually he had MVO. MVO will gradually go away. So when you do some of the serial MRIs on these patients that we've done in our STEMI trials, you know, if you do an MRI a month later to 3 months later, the MVO is all gone by then. But this is still, you know, only 2 days. So, you know, we clearly see MVO at 2 and 3 days, but this gentleman didn't. So why? They both had prolonged chest pain. Is it because one was 3 days versus 1 day? This patient was diabetic and had some diabetic mild ketoacidosis, so his pH was lower, so he's acidotic. Does that have a bearing? Is it male versus female? High versus low end diastolic pressures, which we'll get into when we talk a little bit about extravascular compressive forces. Are they on different medications? And does one and not the other have endothelial dysfunction? So there's a whole lot of things that could contribute to that, of why this one person had a lot of MVO and the other one didn't. So this just shows kind of just the powerful predictive ability of microvascular obstruction. This is 1,000 STEMI patients who underwent primary PCI. And this shows the event-free survival and an event-free from cardiac death, heart failure, and recurrent MI. And you can see the difference. Those patients that did not have MVO compared to those patients with MVO, that there's a marked difference in survival, event-free survival between the two groups. Again, harking back to what I talked about at the beginning of how different these patients are and how they should be accounted for when you're doing your studies. Now, this was an interesting study. This actually pooled 7 different MRI studies that had measured MVO, and they wanted to determine, is just having MVO enough, or does it matter if you have a lot of MVO? So this looked at 3 different gradations of MVO from 2.3%, 4%, and 7% of the myocardium. And you can see here that the all-cause mortality goes up with the higher amount of MVO seen. So just having MVO is bad, but the more MVO you have is worse. Better to have little MVO than a lot of MVO. And then this is another in the similar vein, a multi-center study from Germany of 738 STEMI patients, just looking at the presence of MVO as powerful as infarct size, because we always think of infarct size as just being very powerful, but actually MVO, its presence is just as powerful in predicting event-free survival. And this looked at several metrics such as ejection fraction. So in the top left corner, if your EF was greater than or less than 47%, you can see its powerful discriminating factors. Over here, you looked at infarct size, 19%, greater than 19% or less than 19%. Again, you can see this huge discrimination between the two. Myocardial salvage here, and then down here is MVO on the bottom right. So if you had a lot of MVO, your event-free survival was markedly reduced compared if you had no MVO at all. So hopefully you're getting the gist that having MVO is a really bad thing to have. So now I want to just shift gears a little bit and just show you some examples of how MVO has been influenced and influences a lot of the results of some of the clinical trials that we've been involved in. First thing I want to talk about is ischemia reperfusion injury. And this kind of cartoon just describes all the things that can go on in someone who before, during, and after a STEMI. So before, and that affects the microvascular function and injury. So before the occlusion, the day before the heart attack, you have patients that have significant underlying endothelial dysfunction due to the presence of diabetes or hypercholesterolemia. And then the patient closes off his artery and you get in situ thrombosis and the loss of vascular integrity. But then you open up the vessel, and certainly opening up the vessel is a good thing, but it also leads to what's called reperfusion injury. So all of a sudden that the oxygen-starved myocardium all of a sudden gets exposed to blood and oxygen again, which creates all sorts of free radicals and other evil humors that cause all sorts of damage downstream. You get cellular plugging, you get myocardial edema that can compress the vessels, as it's showing here. You get embolization of the thrombus, you get intramyocardial hemorrhage, which is like MVO, a terrible thing to have. And you get coronary vasospasm from all the humors that are in the thrombus that cause the vessels to close down. And this is kind of a cartoon of how what the contribution is of lethal reperfusion injury, and that it can contribute up to 40% of the final infarct size. So if you look up here at the top, and you can see what's in white are the areas of cell death there by staining. So if you close off your LAD artery in that territory and do nothing, your infarct size is going to be about 70% of the area at risk is going to die. Now, if you open up the artery with primary PCI, you can reduce that infarct size by 40%, but you still have cell death. And here, if you open up the artery and then you add cardioprotection, and this can be shown in animal models, that you further reduce significantly reduce the infarct size, such that you're only left, you go from an infarct size of 70% down to 5 to 10%. So this reperfusion injury it's real, certainly real in animals. It's just been very difficult to show and to treat in humans, and we've largely been unsuccessful for the most part in really coming up with drugs or techniques to stop this reperfusion injury. But one technique that had and still has some applications is what's called postconditioning. So that's the application of brief periods of ischemia during the initial phase of reperfusion. So this can easily be done in the cath lab, and this was first shown to occur in dogs almost 20 years ago, and it resulted in a 50% reduction in infarct size. And what you do is you have an occluded artery, you bring your balloon down, and then you initially open up the vessel, but you only open it up for like 30 seconds, and then you inflate your balloon, and you perform about 4 cycles of this occlusion, open, occlusion. So you're kind of staggering the reperfusion to the vessels, and that actually showed a marked, in the dog at least, a marked reduction infarct size by 50%. So why would that work? Well, the hypotheses are that repeated occlusions maintain the acidosis to keep this mitochondrial permeability transition pore from opening. and this is kind of the end effector of myocardial and cardiomyocyte damage, is this MPTP channel, which is located on the inner mitochondrial membrane. And when that thing opens, you end up getting a lot of reactive oxygen species, calcium, hydrogen ion, and a big osmotic load that gets into the mitochondria that'll lead to swelling and rupture of the mitochondria and resulting in cell death. And so this acidosis may keep that channel from opening. Just like when I showed you that patient with diabetic ketoacidosis, he was a little bit acidotic. So that's why I said, well, could maybe his low pH have contributed to his lack of MVO? We're not sure. It also, the other hypothesis is delivery of oxygen during reperfusion promotes reactive oxygen species formation, but can activate these kinases through redox signaling, which can actually be beneficial. So here is just kind of a cartoon of, here are some of the compounds, circulating compounds that are thought to be involved in myocardial protection, such as adenosine, bradykinin, opioids, as well as other IGF-1 and FGF-2 that activate these G-coupled receptors on the cardiomyocytes, which in turn activate this risk pathway. So this is reperfusion injury survival kinases. So a kinase is a protein that phosphorylates another protein, and so the key one is this AKT, which is involved in phosphorylating nitric oxide synthase. So having nitric oxide around is a good thing. Also, kinases also activate this glycogen synthase kinase 3 beta, which is also on the mitochondria, which is also important for mitochondrial protection. Again, here's that MPTP channel there. So believe it or not, we use cyclosporin to, blunt rejection of transplanted organs, but cyclosporin also blocks this mitochondrial permeability transition pore. So this group in France did a small study 10 years ago, 58 STEMI patients, and they randomized them to cyclosporin versus normal saline during reperfusion. And these patients had similar ischemic times and cardiac function prior to PCI. And what they looked at, they used the amount of creatine kinase, which is like a surrogate for infarct size. And the more CK that you release in the blood, the more myocardial injury there is. And you can see that that it reduced infarct size by this metric by almost half, from 248,000 units under the curve to 138,000 under the curve. And so and same thing with troponin when you measure that instead. So both CK and troponin showed similar findings. So this led to a large phase 3 study called CIRCUS of 970 STEMI patients. But unfortunately, what they found was that the cyclosporin in this case did not improve the clinical outcomes or LV remodeling at 1 year. And this was published in the New England Journal in 2015. But remarkably, they ended up using a different formulation of the cyclosporin in this trial compared to what they did in their pilot study. And so now they have buyer's remorse, and they're just wondering if the different formulation may have contributed to their negative finding. But unfortunately, like so many things, it works great in animals, but then we get to, or it may work great in phase 1 studies, but when we get to phase 3 studies, that it just doesn't pan out. Now, here's a study looking at post-conditioning that I mentioned from Korea of 700 Korean patients with STEMI, randomized to post-conditioning plus PCI versus routine PCI. And one of the things about post-conditioning to work is once you open that artery, you have to start that intervention of the occlusion and opening of the vessel. You have to do that within 1 minute or you totally lose its effect. So unfortunately, what they did in over half their patients is that they did thrombus aspiration. So they clearly had violated that tenet of getting the post-conditioning routine started within 1 minute. And as a result, they found no different in ST segment resolution, blush grade, or MACE between the two groups. But again, we hypothesized that, well, they really didn't truly do post-conditioning because they did the aspiration thrombectomy first after the artery had already had some reperfusion established with the guide wire. So we developed a post-conditioning study here that was sponsored by the NIH that we finished a couple years ago. And we felt that there were positive and negative trials of post-conditioning out there. And we had done a phase 1 study that looked positive in like 50 patients several years earlier. And we felt that the inconsistent findings in these studies may due to patient selection effects that make post-conditioning ineffective. So this including patients that had prolonged ischemic times. After the artery's closed for more than 6 hours, there's unlikely to be much salvage. Not excluding collateral blood flow. So, you can have an occluded vessel, but if you have collateral blood flow to that territory, then that area is going to survive. The occurrence of limited reperfusion, so excluding patients that had TIMI flow of 1 or 2, so they clearly have already getting some reperfusion, which again would violate that tenet of having the artery totally closed. Failure to exclude patients with pre-infarction angina. We had done an earlier study showing that pre-infarction angina or having stuttering chest pain before the artery closed is very protective of myocardial infarction. And then again, the failure to perform your post-conditioning immediately upon reperfusion with the angioplasty balloon. So this was a single center study that we did. Jane was a huge part in getting this study done. It was a very frustrating study because of a lot of all the regulatory issues that went on that we'll just mention here shortly. But we designed this study to limit the ischemic times between 1 and 6 hours. They had to have 100% occlusion of a major epicardial artery. We excluded patients with pre-infarction angina or collaterals. And we used cardiac MRI measurements of infarct size and myocardial salvage and immediately initiated the post-conditioning protocol upon reperfusion. So there's no early, thrombus aspiration that was done in some of the other studies. These patients were directly admitted to the cath lab as part of the level 1 protocol. And then if we found if the patient had an occluded vessel, then we would do a verbal consent, which allowed us then to proceed. But then the IRB halfway through the trial said, nope, you can't do verbal consents anymore. So we ended up having to go through this long rigmarole of getting an emergency waiver of consent through for the remaining patients, which really delayed our study for over a year, but we were able to get back on track and finish it. So our protocol was 4 30-second inflation and deflations upon immediate restoration of flow by the guide wire. And then we performed cardiac MRI 1 to 3 days, and again at 3 and 12 months. And our primary endpoint was infarct size in myocardial salvage and the amount of MVO between the post-conditioning and the control group. So here's the baseline data. Pretty much they were evenly distributed between the two groups, except the LV mass was slightly higher in the control group, but otherwise their ejection fractions were slightly reduced at around 53%. Their volumes were up slightly, but were similar. Their infarct size was 22 to 24 grams. Their area at risk was 31 grams, and the salvage index was similar, around 30%. And they both had MVO, 29 out of 65 in the post-conditioning group, and 22 out of 57 in the control group. And this is what we found. We found actually that post-conditioning had no benefit whatsoever on reducing infarct size, given the same area at risk, or myocardial salvage. So this was certainly disappointed, and in our eyes, this said that, all right, post-conditioning does not work in humans, at least initially, because we did everything to control for these patients. They were all optimized to show a benefit of post-conditioning, and nothing happened. So then, as I said, we did long-term follow-up, and then things started to get a little more interesting. So first of all, you can see here, so there was some drop-off in the amount of patients that were able to come back for their 3 and 12-month MRIs, but these are the patients that did all the follow-up. You can see that ejection fraction improved in both groups from like 55 to 61%. Now in the post-conditioning group, the end diastolic volume actually went down, whereas in the control group, it actually went up. So the remodeling, both in the remodeling was significantly beneficial with having post-conditioning to compare to control, where similar amount of infarct size, you can see here that your infarct size goes down over time as the infarct size is resorbed and the edema is resolved. So we found then that at least it was a long-term benefit on LV remodeling. But more interesting, then we broke this down by patients who had microvascular obstruction. Those that had MVO that underwent post-conditioning had less MVO as a percentage of LV mass and infarct size, 6 versus 8.4%, and 30.5 versus 37%. So post-conditioning, it didn't change the number of patients that had MVO, but it reduced the amount of MVO that patients had. So that too was also encouraging. And then when you looked at the remodeling of those that had MVO, those that had post-conditioning had better improvements in ejection fraction. You can see that their end diastolic volumes actually went down a little slightly where they went up in the control group. Same thing with end systolic volumes here. So clearly, if you had MVO and underwent post-conditioning, you did much better as far as LV remodeling and function. So we concluded then that although post-conditioning did not reduce infarct size or myocardial salvage following STEMI during in an optimized enrollment patient, it was associated with improved LV remodeling at 1 year. And subjects with MVO randomized to post-conditioning had smaller infarcts at baseline and less adverse remodeling. So it was, it had a delayed positive effect. So it may be that a lot of these studies that have found these ischemia reperfusion trials, none of them do any long-term measurements. And it may be that we're missing something, that there may be a long-term benefit, and we shouldn't maybe give up so soon by just the initial MRI. So now I want to shift gears for a second and talk about the role of microvascular obstruction in our cell therapy studies. And I'll use the TIME trial, which was done here as part of the Cardiovascular Cell Therapy Research Network. This, again, was sponsored by the NHLBI. And we'll compare the 6-month and the 2-year data. So this was published in JAMA and several years ago, and this was 120 patients who had anterior STEMIs, and we randomized them to cell therapy, 150 million bone marrow mononuclear cells versus placebo. And what had never been done in a cell therapy study before was to see if is there an optimum time to give these cells. So they were randomized to either placebo or stem cells on day 3 or day 7 following primary PCI. And this is what we found. We found that it didn't matter, that there was no difference in improvement in ejection fraction at 6 months between the cell therapy group that went up from 45 to 48 or the placebo group that went up from 44 to 48. And when you broke it down by day 3 or day 7, compared to the overall, there was like a 3.3% improvement in ejection fraction in both groups. So the administration of these cells did not help improve ejection fraction. So that was disappointing. And this was at the same time we presented this, there was the Swiss AMI study that also found similar results that I did. So this sort of that the CCTRN did. So this sort of put kind of a nail in the coffin of using these cells in the setting of STEMI. But we did, one of the nice things, again, we had long-term MRI follow-up in these patients out to 2 years to see if there was some kind of late effect. So out of the 120, we ended up with 85 patients that completed their 2-year follow-up. And again, that's the problem with long-term imaging studies, is you do get a lot of dropout. So in that time, we had 10 patients that had ICDs put in. And at that time, we weren't doing MRIs and ICDs like we're doing now in our more modern stem cell trials. Three died, 7 were lost to follow-up, and 15 had contraindications to MRI, most likely, claustrophobia, that they just didn't really want to come back. But here's the change in ejection fraction over 2 years. Again, at 6 months, you get a small increase, and that remained stable in both the BMC and the placebo group out to 2 years. This again shows, just like I showed in post-conditioning, you get a marked like 30 to 40% reduction in infarct size over the first 6 months. And then that continues to a slow, small decrease in infarct size in both groups when looked out to 2 years. Change in end diastolic volumes between that there's overall an increase in slight increase in volumes that maintained stable. And again, these were all on maximal medical therapy, so they did not have worsening adverse remodeling, which was good. So now what we did is we broke the patients down by the presence or absence of MVO. And so you can see here all the discriminating things that show up when you look at MVO. So first of all, the age was no difference, 58 versus 55, but there was a marked sex difference between males and females. If you were a female, then only 1 out of 15 females had MVO, where 14 out of 15 females who did not have MVO. Infarct size was significantly higher if you had MVO as expected, just like in peak CK, again, a surrogate of infarct size, was significantly higher. The ejection fraction with MVO was significantly lower, 43 versus 46, and the LV volumes were significantly higher, end diastolic volume of 80 versus 71, and end systolic volume of 46 versus 38. So again, you see how MVO creates a totally different class of patients that are at much higher risk. So we went back and looked at what were the changes that we saw in the people with MVO. And you can see if you had MVO present that your end diastolic and end systolic volumes were significantly higher than if you did not have MVO, where end systolic volume didn't change at all. And then if you looked at the change in ejection fraction, if you had MVO, you had no improvement in your ejection fraction, whereas if you did not have MVO, you had a 6% improvement in your ejection fraction, again, showing the powerful discriminating factors of microvascular obstruction. So then if you look now, repeat those measurements, just looking with the people with and without MVO, you can see again that the ejection fraction is significantly higher, and that's maintained out over time if you did not have MVO. Your infarct size was similar, the reduction in infarct size was similar over time before the two groups. Your end systolic volumes, though, were much more preserved without MVO compared to with MVO. So we concluded then that intracoronary delivery of autologous bone marrow mononuclear cells delivered 3 or 7 days following STEMI did not improve LV function or attenuate LV remodeling at 6 months, and this sort of was the end of using this cell type in post-STEMI patients. And that LV function volumes and infarct size remained stable between 6 months and 2 years as measured by cardiac MRI. But the presence of MVO was again associated with significant reductions in the recovery of LV function. There's greater adverse LV remodeling. And we also noted an increased need for ICD implants. So there was 10 ICD implants in the group, and 8 of those went to the people that had MVO. Only 2 patients that did not have MVO required ICDs. And these were relatively large anterior infarcts. So again, showing how MVO rears its ugly head. So now the third thing I want to talk about is the circadian basis for the onset of myocardial infarction and tolerance to ischemia and microvascular obstruction. So everyone is aware of so many processes in our body are regulated by light through these circadian rhythms or cycle, where light entrains this master pacemaker in the suprachiasmatic nucleus in your brain, which then synchronizes with a lot of these peripheral, what are called clocks, which are a series of transcription and translational feedback loops that synchronize a lot of different diverse metabolic processes. So over here you can see and it's all triggered by the day-night cycle. And you can just see here how this suprachiasmatic nucleus affects the pituitary gland that releases ACTH, that affects the adrenal glands, that releases catecholamines and glucocorticoids. So this is sort of a cartoon of how the circadian regulation of vascular tone. And this has, just diverse implications for all processes in your body have a circadian regulation. So way back 30 years ago, Jim Muller, I think it was at Harvard at the time, showed that most heart attacks that people have occur early in the morning, usually between 8 and 11 in the morning here. And similarly, the same thing happened with stroke, that most of your strokes also occur around a similar time. So why is that? So they looked into that, and they found that in the morning there's an increase in platelet aggregability that can then lead to thrombus formation and acute MI. And you can see here that your catecholamines go down before, but then they start going up again, and that can lead, so you have several factors that are contributing to making you more predisposed to forming a thrombus, and that's one of the reasons why they believe there's more, heart attacks early in the morning. So Martin Young, who's at University of Alabama, did this really interesting study with just the progress in genetic alterations in animals. They actually created this mouse where they actually ablated these clock genes. So they get rid of the circadian influence in these animals. And what they wanted to see is if the tolerance to ischemia has some time of day dependence. And so they compared the wild type, the normal mouse up here, versus the mutant mouse that had the genetically ablated clock genes. And what they found was that in the switch from light to dark, and this is a mouse, so it's different, they're nocturnal animals compared to us, but you can see here that the infarct size significantly varies over a 24 cycle. And they all received a 45-minute occlusion of their left anterior descending artery. But this just shows that there's a significant difference in tolerance to ischemia over the 24-hour cycle, and it's varied between the light to dark transition. And so they looked at some mechanisms here, and what they found was that there was a nadir in the phosphorylation of that protein, again, AKT, that's a prime phosphorylator of like eNOS and other proteins, and the GCSK3 beta. So there was a mechanism here, again, that the circadian regulation of some of those proteins leads to greater infarct size. So David Leffer, who's a really sharp physiologist, wrote an editorial with that paper and said, is there a better time of day to have a heart attack? So we thought, what a provocative question. We should see if we could actually answer that. So what we did is we looked into this in humans and published this in Circulation Research back in 2012, and is accompanied by a nice editorial by Eugene Brunwald. And so what we did is we started with, we have this great STEMI population from the level 1 protocol. We started with 1,000 patients who had STEMIs with ischemic times between 1 and 6 hours. And then we winnowed it down to get basically 165 pure patients. We excluded CABG, or any that had pre-infarction angina or post-conditioning, because again, that can influence infarct size. So we had 165 patients in our analysis, and we looked at when did they have their heart attack, and did the amount of heart attack damage vary depending on when it was. And indeed, we found that the peak onset of injury looked somewhere between like midnight and 2 a.m. And this correlated with, in a small subgroup, we had actually MRI measurements to show that the peak CK that we used as a surrogate for infarct size actually was supported by the MRI. And we also looked at LV function 2 days after STEMI and found that the peak ejection fraction was about 7% greater in trough. So there's actually even a change in ejection fraction as well. And following this study this was done by Ron Ryder, who was one of our cardiac fellows at the time. These studies were subsequently confirmed in several studies from Europe. So there does, in humans, also appear to be a time of day dependence on infarct size. And this whole issue of circadian regulation of these processes in your bodies are now being expanded to all different types of medicine, such as giving radiotherapy in cancers, giving chemotherapy. Studies have been shown that depending on how you actually vary the light-dark cycles in the ICU, patients will do better or worse depending if they're able to train their circadian rhythm. So this is going to be a huge growing field of looking how you can modify the circadian regulation of a lot of processes in your body. So we thought, and now finally, just to conclude, I want to talk about a couple novel mechanisms of MVO that we've been investigating with our summer interns who have been great. And so the first thing was, could there be a circadian basis for the development of MVO in the setting of STEMI? So And that was, I showed you those earlier things, that there's a circadian basis for infarct, there's a circadian basis for coagulation factors, so maybe there's a circadian basis for MVO, and then also what's the role of extravascular compressive forces in moderating or modulating microvascular obstruction. So this is what Nicole Bonfig, who's one of our summer students, who's now starting medical school at the U this year. We combined 3 of our previous studies where we had MRI measurements. This was our pilot study using these bone marrow mononuclear cells that ended up being the basis for starting this time trial that we did with the CCTRN. And then also our post-conditioning study where we also had MRI measurements of infarct size and MVO. And so what Nicole did was we had a total of about 300 patients that had measurements of infarct size and MVO. And so what we did is that we looked at, we measured the MVO based on what time the patients had infarcts. And so we broke these down into 8 3-hour intervals. And what she found was that there was a significant increase in MVO in this time period between between 6 a.m. and 9 a.m. with kind of a secondary peak later on in the day between 6 and 9 p.m. So this is something that we're hopefully going to dive into a little deeper to see if there really is a kind of a circadian basis for MVO. And the second thing that we've been looking at is what's the role of increased extravascular compressive forces. Some of that cartoon I showed you earlier on, how the microcirculation is so fragile and thin-walled and can easily be compressed from increasing myocardial edema, for example, that happens in the setting of acute myocardial infarction. So the vasculature is embedded in the myocardium that results in compression and systole. So that's why the majority of your coronary blood flow occurs in diastole. But even in diastole, there is some compression of the microvasculature that's dependent on a surrogate for that would be the left ventricular end diastolic pressure. And it's also dependent on increased wall stress, which is increased with LV myocardial mass. So we wanted to look at what is the role of end diastolic pressure in microvascular obstruction and what's the role of myocardial mass. These are 2 things that we can measure, the LV mass by cardiac MRI and the end diastolic pressure at the time of their STEMI presentation by just putting in a catheter in at the time. So what does this mean, this extravascular compressive forces, and how do you measure these? So these are studies I did in Bob Baki's lab about 20 years ago in the chronically instrumented dog. And so what you can do is you can put a flow probe on the LAD artery to measure coronary blood flow, and then you can put an occluder above that on the artery that you can basically inflate small amounts of air, and you can basically create a stenosis. And if you put in enough in, you can totally occlude the vessel. And then what you do is you give adenosine, so you maximally dilate the circulation, and then you slowly close that artery, and then you can measure, also have a catheter in that artery that will measure pressure. So you can measure basically the downstream pressure in those vessels at the time when there's no coronary blood flow, and that's a surrogate for the extravascular compressive forces. And we did this in both normal dogs and dogs that develop heart failure. You can put in a pacemaker in these dogs and then rapidly pace them at 240 beats a minute. And within 2 weeks, they'll develop congestive heart failure. And increasing left ventricular end diastolic pressure is associated with congestive heart failure, and indeed that's what these dogs do. So you can look at here is that so you dial down the blood flow by increasing the stenosis, and then you can basically stop blood flow and then measure the pressure in the downstream. And so in a normal heart, it was around 11 millimeters of mercury, whereas in the failing heart, it was around 27 millimeters of mercury. So that difference is a surrogate for end diastolic, the pressure and the extravascular compressive forces. And you can see here, it's called the zero flow pressure. So that as you increase, it's the resistance actually to perfusion. It's sort of like the back pressure that keeps the blood from flowing into the microcirculation. And it's highly correlated, again, this zero flow pressure is correlated with the end diastolic pressure. So first of all, Nicole measured the infarct size an MVO mass. So first of all, we showed that many people have shown before that the bigger your infarct size, there's a nice relationship, you have more MVO. But what not had been shown before was that MVO is totally is predicated on your LV mass. So as you have increasing LV mass, you get more MVO, and this is consistent then with, we know like patients that have hypertrophic cardiomyopathy or have severe LV mass have very significant increases in extravascular compressive forces. So we think that this is also saying that if you have more LV mass, that your extravascular compressive forces are higher, and so you're going to have harder time perfusing your microcirculation, and so you're going to end up with more MVO. And then just this summer, Ananya Shah spent the summer with us before going back to college, and she went through our data from the cath lab looking at end diastolic pressure, and what we found was that if you had MVO versus not MVO in around 300 patients, that patients with MVO had a statistically higher end diastolic pressure than those that did not have MVO, again suggesting that there is this extravascular effects that may contribute to the development of microvascular obstruction. So I'll just conclude by this review that was just recently published by kind of the luminaries in ischemia reperfusion injury and cardiac physiology, such as Gerd Heusch and Derek Hasenloy and several others from this is all Europeans. And basically what they were is sort of a call to arms that we need to do something about MVO. To me and to them, I think MVO remains the most important remaining target in STEMI. We now have early reperfusion, we've increased awareness, we developed the level 1 centers, but we still haven't found a way yet to get rid of this MVO. And currently there's no therapeutic options to reduce MVO. There have been some small trials that suggest that some drugs may be a benefit, such as statins or beta blockers or anti-inflammatory medications. But there's no drug that has been consistently shown to reduce MVO. So what we really need is like an MVO Manhattan project to try to figure out how we can stop MVO, because hopefully now after this morning, I've shown to you that how important having MVO is and what a detriment it is to a patient's prognosis. And I'll stop there, and thanks for your attention. If anyone has any questions.
Have you seen any difference in people that work night shifts versus day shifts? Do their rhythms shift with?
The rhythm, it's not a good thing to work the night shift for your health. I mean, I think there's a lot of data out there that they have more, their cardiovascular risks are higher, and part of that probably is that, you're trying to change their circadian regulation, I think, of a lot of their cardiovascular system. So I think people on night shift should get paid more or something.
Get more life insurance.
Yeah.
Fascinating topic, and thanks for going over your immense amount of work on this field. I have two questions. One is, what do we know about the use of thrombolytics? Because there is also the thrombosis that occurs downstream, right? And thrombectomy. I mean, does that have any bearing on the MVO size? And the second is, trying to leverage some of the technology we currently have at MHI, also to understand, in this process. I like the correlation between the mass and the MVO size. It makes sense. But can we detect that a priori in terms of perfusion reserve and things like that? Could this also be a surrogate in addition to the MVO size and how these hearts will respond?
Right. So, all right. So let's start thrombolytics. There are some small studies that show, like given, intracoronary thrombolytics or giving, glycoprotein 2B3A receptor antagonist down the coronary artery shows some benefit, but not consistently. As far as the aspiration thrombectomy, it makes so much sense. You just get rid of the thrombus, and then you're going to have less embolic debris and less MVO. But when they do the big studies, they're totally neutral. So, to me, it raises that maybe external compression may be more important than we realize, and that's something you can't control for with the stuff going on inside the vessel. And I think what you guys do, I mean, I think you guys are the key going forward to, you know, helping us figure out how, you know, because I think, first of all, we need better measurements that we can get through MRI, and we need more data looking at the factors that cause MVO. I mean, the whole thing about hemorrhage too, that's a really big, you know, issue that goes hand in hand with MVO. And I think Rob Schwartz is working on some compound to try to reduce, I don't know if it was try to reduce hemorrhage or whatever. I'm supposed to meet with him because he's trying to get a clinical trial to go through this, and it'll be interesting to hear what he had to say. But certainly if there's some way of stopping, you know, that's all due to vessel integrity and just all the damage that comes on to the vessels, microvessels with reperfusion injury and so forth. So, so I think a lot of the future is going to be in the hands of the, you know, the MRI readers, and as far as giving us, you know, kind of mechanisms to pursue.
I have Dr. Lesser here on the phone. Dr. Lesser, can you please state your question here?
Fantastic. Have you looked at infarct extent with T2 mapping?
Infarct?
And compressive forces relative to MVO?
No, we haven't done that. I think in our, I mean, I don't know, we have the data, is that something we had to do a priori, or would we routinely do some T2 measurements that are there in these patients?
We should have it, because if the T2 images were acquired, we can calculate what is the area of edema and.
Right, so I know we were, right, so we were measuring, some of the, we do, at least the post-conditioning study, have the amount of edema and everything. That to me is a hard thing to really, seems like it's a difficult thing to quantify. There's some evidence like edema has a bimodal distribution, that it may peak early and then resolve and then come back again several days later. So I think the timing of when you do your MRI is you know, really important as well.
Several online questions. The first of which is, what about adenosine? Sorry for the pronunciation.
Oh, that's perfect.
Or drugs/devices which decrease after load.
So adenosine is actually, in some studies, has been shown to be protective in anterior STEMIs, but not in others. So I think, you know, as I showed you that cartoon of the cascade of kind of proteins that are that risk pathway, adenosine is one of the kind of chemical compounds that at least in animals clearly has a benefit in reducing ischemia reperfusion injury. I think again our big issue is with so many things in medicine, the thing works great in the mouse and the rat, and then as we get to the pig, it's still, oh, it's okay, and then you get to the human, and we're really losing you know, a lot there. But there has been some interest in adenosine. And as far as afterload reduction, you know, there's this whole big study with you know, with Impella that they're trying to get going in STEMI to, you know, they have data showing that infarct size goes down when you reduce, you know, afterload and preload. So we'll see. I know there's trying to get that study off the ground, because it's quite an invasive thing to put a huge catheter in there, you know, in the setting of STEMI when they're all anticoagulated and everything. So, but that's a good question.
Yeah, thank you. The next question comes from Dr. Bradley, who asks, how do you account for differences in processes of care that are associated with time of day when looking at STEMI associations by time of day?
Right. So, so I think, you know, that's the whole, I guess, conundrum of, like, you know, do people do worse on weekends versus, you know, during the week? I think that's what he's getting to, because, you know, maybe you don't have your full contingent of all your staff around. Same thing like when, are you going to do worse in July when all the new interns start compared to later on? So that I would say that would be a limitation of our study. We measured it as far as we had good measurements of when their chest pain started as a surrogate, and we knew when the artery was open. So we had a good measurement of ischemic time. Is there delay in, transport? I think our level 1 program sort of helps reduce that, but I think, clearly people at nighttime maybe hope it goes away and they don't show up to their ER. They don't want to have their loved one wake up and take them to the hospital. So that is a limitation, but we didn't find that was, a significant contributing to what we found of why the infarct was greater at that midnight to 1 a.m. time.
Yeah, it's very interesting. It looks like we have one more question. And that question is, great talk, Jay. This is from Dr. Chavez. Can you comment on Impella LV unloading and MVO? There's a lot of interest in this mechanism to reduce infarct size and CHF. As you know, the door to unload study is currently enrolling and may be important in answering this question.
Right. So I was just talking about the Impella device. So I know they have very interesting animal data showing that if you unload the ventricle that you're going to reduce infarct size. I'm not familiar with them showing a reduction in MVO. I know they showed that the infarct size went down and that the LV function was better, but I wasn't aware that they had any MVO data, but that certainly would be important to look at. And then I think we were going to try to start that, Manos was trying to get that study up and going here, because we had the PI spoke at our grand rounds here, I think, a year and a half ago or so. So I think we're going to try to do that. It's just, they did publish some early data last year at American Heart Association, and in truth, it was, even though it was featured presentation, the data wasn't that, I didn't think the data was that compelling. Because the numbers were so small and the scatter was pretty high. But it certainly, physiologically, it makes sense. It's just, are you going to achieve enough benefit for the risk of putting in like a 16 French catheter, in your artery with all the risk of vascular complications and everything at the time of STEMI? So I think that's the big trade-off with that.
Excellent. Well, thank you very much. That's all we had for online questions. So
yes.
One quick question is, how do you see the development of MVO assessed in routine practice? But how can you image MVO in a simplified way to make it enter routine practice?
Right. So I think the simplest and cheapest way is the EKG. If they have persistent ST elevation on the EKG, I think that's a fairly good surrogate. It would be nice if there was a biomarker, for MVO. And I don't know, Joe, are you aware of any biomarker for MVO yet that you could? That would be really if we had a biomarker, but I'm not aware of one. So I think you're left with the EKG is probably the cheapest surrogate for having MVO. Well, thanks a lot.
Thank you.